Hi, I'm Grefkes. I welcome you to the OHBM-DGKN Alliance Symposium on Network Reorganization after stroke. Together with my co-chair, Steve Small from University of Dallas in Texas, we will chair this session, which has the focus on stroke and network changes induced by stroke and their potential impact on new therapies. So we have invited 4 speakers, including ourselves, which address these questions from different perspectives. The first speaker will be myself, Grefkes. I will talk about principles of brain reorganization after stroke. Then Adrian Guggisberg from Geneva in Switzerland will talk about the importance of intrinsic network states for stroke plasticity. Then Steve Small will give a talk about network neuroscience of language recovery after stroke. And the final talk of this session will be given by Professor Nick Ward from University College London in England about advancing upper limb recovery after stroke. I hope you will enjoy this symposium, and now I wish you a nice conference. And if you have questions, please do not hesitate to ask us live or send us emails in case that you cannot make it online. Enjoy.
Hi, this is Grefkes from Cologne, Germany. I welcome you to the second OHBM-DGKN Alliance Symposium on Network Reorganization after Stroke. I will start this session with the first talk entitled Principles of Brain Reorganization after Stroke. Stroke has the most dominant impact on healthy life years worldwide. Therefore, it is important to study the underlying mechanisms enabling recovery of function after stroke. We already have a number of therapies at hand which allows to improve the outcome after stroke, for example, thrombolysis or more recently, thrombectomy. These are very effective causal therapies to overcome the problems caused by a stroke. However, they can usually only be applied to a small fraction of patients. And even those patients who will receive these kind of treatments keep a permanent deficit. These numbers will even increase in the next decades due to the ever-increasing number of older people in our societies. And therefore, it is very challenging to improve not only the treatment in the acute post-stroke phase, but also to improve prevention of strokes, but also to improve post-stroke therapies beyond recanalization therapies, which can only apply in the first hours after stroke. And here, imaging plays an important role, especially when it comes to human stroke research. As you might know, most therapies which work in animals have thus far failed to be translated into the human world. And one reason for that is probably that the human brain is much more complex and also very different in terms of network architecture compared to animal brains. And therefore, we need primary research in humans to address these questions, especially when it comes to stroke recovery research. And here, especially functional imaging has been proven very useful and valuable to observe the neural changes that enable recovery of function after stroke. Here you see an example of 2 patients having left-hand deficits resulting from a right hemispheric stroke. And you can see that the patient on the right-hand side has recovered quite well, while the other patient on the left-hand side still has substantial deficits in this very daily life task. And when we image these patients with fMRI, we can see that their network structure looks very different. The patient who has recovered quite well on the right-hand side has a normal-looking lateralized activation pattern, while the other patient with residual deficits still has a very abnormal bilateral activation pattern. And this has also been shown for other functional domains of the human brain, that especially patients with stronger impairments show additional activity in the non-lesioned hemisphere. And then, of course, the question arises, what is the meaning of these changes in activity? Here again, another example from a group study already published some years ago, where we typically observe activity in the contra-lesional healthy hemisphere in patients with residual deficits. And in order to understand what the role of activity is for the entire network system, we cannot just rely on this graphical description of network changes. For that, we need models of connectivity. And one way to model connectivity is dynamic causal modeling. We have applied this to fMRI time series and could demonstrate for key motor areas, as highlighted here in green circles, unilateral movements of the hand typically lead to increased connectivity in the contralateral hemisphere, here indicated by green arrows, but also we see suppression of activity in the hemisphere ipsilateral to the moving hand. When we do the same analysis in stroke patients, we see that for most interactions, there is no significant difference, as indicated by gray arrows. With one important exception, we see an additional inhibition emerging from the motor cortex of the healthy hemisphere, targeting the motor cortex of the lesion hemisphere, which is not present in the stroke group and which also correlates with motor impairment. However, we also know that these effects typically occur in the early subacute phase and then normalize towards level observed in healthy controls, especially in patients with full recovery. And only those patients who keep a deficit and who develop a negative influence from the unaffected hemisphere to the affected hemisphere are those which have a poor outcome in the long run. And therefore, these technologies now allow us even to show these disturbances between areas. And these findings fit well to the concept of interhemispheric inhibition and disturbances thereof after stroke, and directly impact on putative therapies to overcome these network disturbances. And one approach here would be to suppress activity of the healthy hemisphere, at least in some patients, or to increase activity in the lesioned hemisphere. And one way to do this is transcranial magnetic stimulation, which allows a rather focused change of activity of the cortex. For those of you who are not so familiar with this technique, TMS is already out for about 30 years, or almost 40 years. And this uses short magnetic pulses to induce an electric field in cortex. And this electric field then excites neuronal structures in the brain, and then can also induce a corticospinal volley, which then may induce a twitch in a respective muscle. Importantly, TMS has not only effect on the corticospinal tract, but also affects the entire motor system, as shown here by a study published by Sven Westman already some years ago, where he stimulated the motor cortex inside the fMRI scanner, and then could demonstrate that not only cortex underneath the stimulation coil was activated, but also interconnected brain regions. Therefore, TMS to primary motor cortex activates the entire sensory-motor system, which is especially important when we would like to treat systems-level disease like stroke. And indeed, we have used this technique in several studies in the past decade and could show that it is possible to normalize pathological activation patterns and also connectivity patterns. And these normalizations of network structures are associated with improvements of hand motor functions. Similar effects could be observed when we increase activity in the lesion hemisphere, for example, of ipsilesional primary motor cortex using excitability enhancing TMS protocols, especially when they applied in the subacute stroke phase combined with physical therapy. However, there are still a lot of challenges when we would like to translate these kind of techniques into the clinical routine. There's especially a big inter-individual variability with respect to the responsiveness of our TMS simulations, even in healthy subjects. In addition, there is a lot of variability in patients with respect to network disturbances. Some patients develop these interhemispheric inhibition effects and some do not. And it seems evident that these patients need different kind of network treatments. And finally, there is a strong dynamic in the course of the disease, which with network changes in the early acute stroke phase, which are very, very different from those which we can observe in the same patients 3 months later. So we need to consider all these effects to really have an effective treatment of individual patients. Therefore, we need novel readouts of network disturbances, which are easier to apply in a clinical routine. One way, of course, is to use imaging-based things like fMRI, resting state fMRI, which can be integrated into, for example, clinical protocols. And we have indeed shown that we can use this technique to predict motor deficits using support vector machines, so artificial intelligence techniques, which allows to make predictions based on the pattern of changes in network connectivity. However, thus far, we were not able to use these techniques to make predictions of outcome after stroke, probably because resting state measurements are still very noisy, especially as we are not able to do this for a very long time in patients because they cannot lie still for a very long time. In contrast, when we use simple motor tasks, like 5 minutes motor task, which can also be implemented in the clinical routine, then we can make predictions with respect to motor outcome, especially in those patients which cannot be predicted based on behavioral parameters. However, this again needs some cooperation and other prerequisites which many patients cannot meet. Therefore, fMRI has the capacity to make predictions, but there are still challenges to integrate this technique into really clinical routines. Therefore, other techniques like the combined use of TMS and EEG have emerged recently, which may overcome the limitations which we face when using fMRI or bold signal-based prediction methods. And here, TMS is applied, for example, to the primary motor cortex, and you can see in this video that not only the region underneath the stimulated coil is activated, but you can see that the entire system again is activated. Now, for example, you see the other motor cortex also shows deflections, and therefore this technique allows to extract network parameters in individual patients. And in contrast to fMRI, this technique does not rely on any cooperation. You can even pause, for example, investigations when patients are tired or need a break, which is usually very difficult when you do fMRI measurements. And there are no vascular confounds in this technique, which is especially important when you investigate stroke patients, where we frequently observe problems in neurovascular coupling or vascular stenosis. Here you see the examples how TMS EEG signals look like if you stimulate the motor cortex in an acute stroke patients with a complete paralysis of one hand or one body side. And on the left-hand side, you see stimulation of the healthy motor cortex, and the right-hand side, you see stimulation of the lesion motor cortex. And look how the signals differ between both hemispheres. This is now the TMS pulse happening. And on the left-hand side, you can see that there is a vivid change of reflections in different parts of the brain, while on the right-hand side, we have a very stationary, isolated, high-amplitude response. So this somewhat mimics what we sometimes observe in stroke, in stroke patients in the acute phase when we investigate them with fMRI, where we see abnormal activity in the IPSI lesion motor cortex. And we applied this in a number of stroke patients and could even show that these phenomena can be generalized to a number of stroke patients, and they not only reflect their deficit, but also reflect their potential to recover. Interestingly, even those patients who show very abnormal changes in the very first acute stroke phase, for example, here, this slow wave-like response, reflecting a strong network disturbance, like a differentiation of the motor cortex with the rest of the brain. These effects even change over time. And we are now in the process of understanding these changes in a larger group of stroke patients in longitudinal designs. And finally, these effects are not only found for the motor system, but also for the visual system. For example, when you stimulate the visual cortex using the phosphine threshold with TMS EEG, then you see in healthy subject, or here in a healthy subject, that you can activate the visual system, not only the primary visual cortex, but also secondary and tertiary visual areas here, for example, in the parietal cortex. When we stimulate chronic stroke patients, here you see the stroke lesions in right occipital cortex, and stimulate first the healthy hemisphere, we can see that again, the signal starts in visual cortex and then transmits to parietal cortex. And when we stimulate the lesion hemisphere, you again see a very isolated high amplitude response, which is somewhat differentiated from the rest of the brain. So these results make us very promising, or make us believe that a TMS EEG might be another biomarker of stroke-induced network disturbances, which can be integrated into the clinical routine. And we are currently in the process of testing these hypotheses. So I would like to conclude. I hope I could convince you that connectivity models enable deeper understanding of stroke deficits and functional recovery over time. Especially contralateral brain regions seem to interfere with motor recovery in a time-sensitive manner. And we have now novel electrophysiological readouts like TMS EEG at hand, which might enable individualized motor outcome prediction in the future. I thank my team for all support, and I thank you for your attention.
Hi, welcome to this session on stroke plasticity. My talk will focus on the importance of network states for stroke plasticity. And I hope that I will be able to convince you that we have to take into account not only what's happening during the task, but also during spontaneous activity states. So I would like to start this presentation with a short historic recapitulation on some principles of neuroimaging that we have been using classically. So as you know, when we, for instance, want to study what's happening during motor activity, we will ask patients or healthy participants to move their hands and look at activity that taking place during the task, and contrast this to what's happening during a baseline state that we think is more or less silent or just noise. In EEG, it is the same principle. So we will look, for instance, at activity changes during motor activity, during movements, and we will be able to observe a reduction of spontaneous alpha band activity that is replaced by a faster activity, as seen here, mostly over central electrodes. And we can use neuroimaging techniques, source localization techniques, an EEG or MEG, and localize this to the motor cortex with reductions in slower band activities in alpha and beta band and increases in high gamma activity. And again, classically, this alpha band activity has been thought to represent inhibition or not so important activity for the task. However, when we look more closely at these resting state baselines, then we see that the activity fluctuates, so it's not silent, and moreover, these fluctuations are not noisy. They are actually organized into coherent brain networks, such that brain areas belonging to a common network fluctuate in synchrony between each other. So here in the example of the motor network, you can see that brain areas belonging to the motor network will fluctuate in synchrony in fMRI. With EEG, it's a little bit more complicated to visualize this, but we can now also use source imaging methods to reconstruct what's happening in the brain from surface recordings, and then again also reconstruct collaborations, functional connectivity between brain areas, here for instance between frontal and parietal areas. And again we can then say if they oscillate synchronously, they show high functional connectivity, and this is interpreted as index of higher interaction between these areas. Now let's look at what's taking place in the healthy brain. If we just record healthy persons during a spontaneous resting state, during which they keep their eyes closed, we reconstruct EEG activity in the brain from surface recordings using inverse solutions, and then simply ask how much does a given brain area oscillate in synchrony, oscillate in coherence with the rest of the brain. And if we do this, we will find a peak in the alpha band, which corresponds obviously to the alpha band activity that we have known since the first recording of EEG. And this actually shows that alpha band activity is the preferential frequency for large-scale brain interactions. This has recently also been demonstrated from data in animal experiments. So alpha band activity at rest is actually involved in large-scale brain communication between areas. And we have also found evidence that this is actually behaviorally relevant. So if we correlate the amount of alpha band functional connectivity with the ability of patients to perform a task, and again the alpha band connectivity is reconstructed from spontaneous resting state activity without a task, while behavioral performance is measured during a task after resting state recording. And again we find here that the more a given brain area, for instance the left frontotemporal areas, are coherent with the rest of the brain in the alpha band, the better subjects are able to produce new words. Or similarly, if the more right frontoparietal areas are coherent with the rest of the brain, the better subjects are able to attend to left-sided visual stimuli. And if you now then seed this area here, we can reconstruct the language network consisted of Broca's and Wernicke's area, and the interactions between these areas correlates with language abilities, and interaction between areas belonging to the spatial attention network correlate with spatial attention behavioral performance in healthy subjects. And this is also the case in patients. First of all, if we look at stroke patients, we can observe a loss of alpha band coherence over electrodes of the affected hemisphere, here shown in black, as compared to electrodes over the contralesional hemisphere, or as compared to healthy subjects, shown in gray. If we localize this loss of alpha band activity in two example patients here and here, we can see that both patients had a lesion in the left hemisphere, in the middle cerebral artery territory, shown here in dark gray. Now, this patient had a loss of functional connectivity in left frontotemporal areas, and this patient actually showed Broca's aphasia, but he was able to move his arm normally. In contrast, this patient here had normal or almost normal language abilities, but had severe paresis of her right arm. So you can see a correspondence between loss of connectivity and the neurological deficits that patients exhibit. And if you do this across multiple patients, so these were a total of over 20 patients, we find a nice linear correlation between the amount of brain interaction in the alpha band and behavioral performance. And this was the case for different clinical symptoms. Here for aphasia, so aphasia correlated with a loss of functional connectivity in left frontal areas, and motor paresis correlated with a loss of functional connectivity in motor areas. These areas were actually structurally intact in most patients. So even if you correct for structural loss, this still remains significant. And this actually shows that not only the structural destruction of brain areas are responsible for neurological deficits, but also a loss of interactions of the structurally intact brain areas around them. So if you now recapitulate neuroimaging data, we have seen from classical findings that task-related activations lead to performance. So for instance, motor activations lead to motor performance, visual activations lead to better visual performance. But more recent data has shown that also resting state interactions are related to performance. I've shown you some examples just before. So the question is, how do they relate to each other, and do they actually also interact among each other? We have looked at this in a recent study where we compared the importance of spontaneous network states during rest to task activations. And first we did this in the example of a visual detection task. So these were healthy subjects, and they had to actually detect small visual stimuli that were presented at contrasts just at the threshold of each patient, such that about half of the stimuli were perceived and half were not, at the same external stimulation constant. And we were then able to compare differences in brain activations and differences in brain network interactions in association with trials that were perceived versus trials that were not perceived. So first, we confirmed well-known data that stronger brain activation was related to visual perception. So in this case here, trials that were perceived showed greater theta, alpha, and beta band power reduction in the occipital cortex than stimulations that were not perceived. Similarly, we confirmed that alpha band resting state interaction was associated with correct perception of the stimuli, such that trials that were perceived were preceded by a resting state with greater alpha band interactions than trials that were not perceived by the subjects. And this was not the case in other frequency bands, so it was specific to the alpha band. Now, when we look at the behavioral impact of these changes by correlating the amount of power changes to the perception performance of each subject, we actually had a surprising finding, such that healthy subjects that showed greatest power decreases during perceived tasks were the ones that had the lowest perception performance, in the sense that they needed much greater contrasts to correctly perceive their targets than patients who had very small power decreases only. In contrast, subjects that had high alpha band connectivity here were actually also the ones that showed the best visual perception performance, so they were able to perceive even very tiny contrasts of the visual stimuli. So this shows that the resting state interaction is actually positively associated with performance, while task activations during the task was negatively associated with performance. Why is this the case? We actually found that resting state interactions also influence the magnitude of activation changes during the task. such that subjects that showed high alpha band connectivity, so the 50% of subjects with best alpha band connectivity, actually showed no measurable change in alpha, beta, or gamma changes during the task. Conversely, subjects with lower alpha band connectivity needed much greater alpha band changes. So this suggests that alpha band power changes and beta band power changes, and even the same as actually even the case in high gamma, are necessarily only in subjects that have low alpha band states in their spontaneous resting activity, while they take place as a compensation mechanism in patients or subjects that have lower alpha band connectivity during their spontaneous state. So the classical task-induced activation changes are more a compensation mechanism, necessarily only in subjects that have an unfavorable baseline state of low spontaneous interactions between the brain areas. And you can even see that there's a very strong linear correlation between the magnitude of alpha band connectivity and the magnitude of task-related changes, such that stronger subjects with strong alpha band connectivity had almost no changes in power. And you can see here that actually alpha band connectivity influenced power in all bands that we considered, so alpha, beta, gamma, and high gamma bands. So this was the example for visual perception, but the same can be shown also for motor activity, which might be more relevant for stroke patients. Again, here in the example of a motor sequence task, during which subjects performed repetitive sequences that was constant, and they learned to perform this sequence better and better. And you can see that the correct performance of the sequence was associated with the classical pattern of task activations, but was also associated with high resting state alpha band connectivity in motor areas. And again, subjects that had high alpha band connectivity had almost no measurable change in power during the task. So, so we can conclude that spontaneous network interactions enable efficient task processing without local activations or with little local activation, while local task-induced activation may represent effort and attention that is needed as a compensation for unfavorable network states of the brain. What's more, we have also observed that alpha band connectivity is associated with better learning abilities. Here in the example of a learning task consisting of having to follow stars with a mouse cursor, with the little difficulty that the direction of the cursor is reversed, such that when you move the mouse to the right, the cursor moves to the left, and if you move the mouse to the left, the cursor moves to the right. So this is a mirror drawing task, and in the beginning this is very difficult as people make many errors, and with time they learn to get more precise. You can see the learning curve in this task here, while in the control tasks without inversion of the cursor direction, people are able to do this very nicely already from the beginning, and there's no further learning involved. And now we again observed that subjects with greater alpha band coherence in central parietal areas contralateral to the moving hand were able to learn quicker and better, such that spontaneous activity occurring during the rest favors better learning in motor tasks. And we've also shown this more recently for another motor learning task, the sequential learning tasks. So subjects have to press buttons in a certain sequence, and which always remains the same, and with time they are able to repeat more sequences per minute. And again, in this case, it was basal ganglia functional connectivity in the alpha band that was associated with better learning in healthy subjects. So we can conclude that spontaneous network interactions facilitate learning. This is also the case in patients. We have shown that patients who show high functional connectivity in structurally preserved motor areas are able to show better motor recovery during the first 3 months after stroke. And the same is the case for language. So patients with greater alpha band and beta band connectivity in frontal areas are able to show better language learning during the first 3 months after stroke. So if baseline network interaction states are so important, how can we actually influence them with therapy? The good thing to know is that actually the classical therapy that we apply to these patients, physical therapy, is already efficacious at a certain extent for enhancing alpha band connectivity. We have shown here that if you compare patients before a 3-week training program and after a 3-week training program, we can observe an increase in alpha band connectivity of motor areas, and the extent to which alpha band connectivity was improved during training correlated with the amount of clinical improvement. But then again, this is maybe a little bit limited, and the question is, could we further enhance spontaneous coherence in target areas, and would this then lead to better improvement of the patients? One technique that we have tried out is brain stimulation. And we actually compared 2 types of brain stimulation: transcranial magnetic stimulation, so this is a continuous theta burst stimulation protocol, and transcranial direct current stimulation. And we've seen that especially TDCS was able to enhance connectivity in motor areas as compared to sham stimulation. But I would like to focus today on another technique, which is called neurofeedback, during which patients saw a cursor on the screen, and this cursor moved up and down depending on the amount of alpha band functional connectivity at this given moment in their affected motor cortex. So for each patient, we marked structurally preserved brain areas in the motor cortex of the affected hemisphere, and reconstructed in real-time alpha band connectivity between this area and the rest of the brain, and fed this back to the patient via a cursor that was moving up and down on the screen. And the first thing that we observed is that patients were actually able to learn to enhance alpha band connectivity, especially 10 Hz connectivity in the target area, which is marked in gray here. And this led to a clinical improvement of about 5 points on Fugl-Meyer score. That was significantly better than patients who performed a control training of neurofeedback, but where the target area was defined in the control area, in the contralesional area that was not related to motor performance. Unfortunately, the gain was not preserved at follow-up, meaning that in some patients the gain was lost again later on. So there's still some work to do. But I think as a proof of principle, we've shown that this might be causally relevant. And moreover, we even found that patients who had the best success in enhancing their functional connectivity were also the ones that had the greatest gain in the Fugl-Meyer scores. And these are actually also the ones that were able to maintain their improvement at the longer term. So I would like to conclude in trying to claim that we need to change our intuitive perception on what's happening in the brain by replacing the classical picture of a unique importance of what's happening during the task by a more complex picture where we are aware that the brain is not silent at rest but has spontaneous activity, and this spontaneous activity will influence activations during the task. And it's actually this activity per se that will influence clinical deficits and recovery, even maybe more than what's happening during the task. So this means, as a clinical consequence, that we have to move on from our unique perspective on trying to optimize training by also trying to optimize spontaneous network states that will be present before training and learning and therapy. And the question is, how can we do this? This is actually still an open question. I've shown you a few attempts that we have made recently, but I think there may be other attempts that might be promising. And in general, it will be interesting to see in the future whether whether we succeed in bringing patients and healthy subjects into a state that makes them more susceptible to learn. I would like to thank these collaborators who obtained the data that I've shown here. I would like to thank my funding agency, and I would like to thank you for your attention.
Good day, and welcome to the 27th annual meeting of the Association for Human Brain Mapping. I'm Steve Small from the University of Texas at Dallas, and I'm honored to be part of this special symposium at OHBM on stroke recovery. My disclosures are limited to the US federal government, the University of Texas at Dallas, some private philanthropy, and when I was editor of Brain and Language, the Elsevier Corporation. Today in my talk on network neuroscience of language recovery after stroke, I'll focus on three guiding principles. First is that human language evolved from the sensory, motor, emotional, and social functions of the primate brain. Second, that human language performance involves multi-system interactions across complex spatial and temporal representations in the human brain. And finally, that individual differences are paramount and that personalized or precision approaches to therapy will be critical. First, the evolution of language from sensory, motor, emotional, and social functions of primates. We've known for at least 20 years, and perhaps a bit longer, that the motor system in the primate, the motor cortical functions of the primate, are localized to a whole bunch of different regions in the frontal lobe of the brain and parietal lobe of the brain. This primate data have been replicated in human thanks to functional MRI and PET. And so we know a lot about the motor cortical regions of the human brain, and we're beginning to get an idea of the connectivity among them as well. In the visual system of the primate, there are known to be two systems discovered many years ago by Leslie Ungerleider in Mortimer, Michigan, in which the identification of objects, the so-called what pathway, is a ventral route, and the where or how pathway, where objects are in the scene or how they're used in a motor sense, takes place in a more dorsal pathway. So this ventral and dorsal stream notion originated in the visual system in this work. And subsequently, the dorsal and ventral streams were discovered related to auditory function as well. This was mostly done by Josef Rauschecker and his colleagues. And so the identification of auditory objects and their localization or use took place in different streams, the identification more ventrally and the localization more dorsally. In human, these data from visual and motor systems have been brought to human, and we now understand the language systems of the brain also in terms of dorsal and ventral systems. But if you look at the image on the right of the connectivity, the white matter connectivity among regions that are involved in language, we find that this set of streams is actually really like superhighways. And what I mean by that is that it's not a point-to-point connectivity like an electrical circuit, but it is a whole bunch of different entries and exits from this large stream. And so there are regions of the brain that project to many, many other regions of the brain, all in service of language. We do divide these now, and this is very rough, an approximation, into a dorsal set of pathways and a more ventral set of pathways. It's important to realize that because of this, this enormous complexity of language, and I put on the bottom right of the screen some examples of elements that come into play in processing language, from sounds and phones and speech all the way to gestures and humor and emotions and social function. Because of the enormous complexity of language in the real world, that is the natural world, in fact, the regions that are language regions, so to speak, are really many, many, many regions of the brain with a very, very complex connectivity. It's my view, and if we were in person, and next year, hopefully we will be, we could talk about this in real life. But it's my view that virtually the entire brain has evolved to be involved in language processing, including subcortical areas and cerebellar regions, which are not shown in this caricature. So let's discuss the human language performance involving multi-system interactions across complex spatial and temporal representations in the human brain. We're not the first to understand the brain in terms of connectivity. One of the founders of the entire field of neuroscience, Santiago Ramon y Cajal, understood that in the late 19th century. And in stroke recovery, von Monikoff understood this and realized that when there was a lesion in one part of the brain, there were other parts of the brain that were affected. And typically those areas that were affected had some connectivity, whether functional or structural, with the affected area. And even the pioneer of localization, one of the pioneers of localization, Pierre-Paul Broca, who described this case of aphasia in 1861 with a lesion of the left inferior frontal gyrus, really never understood the full extent of injury in that brain because he never cut the brain, which would have been the way in those days to understand what the full extent of injury was. So he never cut the brain, but earlier in this 21st century, Nina Jonkers and her colleagues were able to perform a magnetic resonance imaging scan on this brain and found more widespread damage than Broca could have even imagined. So let's take all this information, this groundwork that we have so far, and discuss how to use it in service of therapy. And the way we did that is in our laboratory, we took this action observation circuitry that occurs in the dorsal pathways. We call it the posterior dorsal pathway. And we use the fact that there's an action observation system to develop a therapy based on action observation and imitation. And it targeted this dorsal stream. We had an opportunity, this was an opportunistic event. A company came to us and asked if we wanted to try an implantation, an epidural implantation system that they had developed for motor recovery, whether we wanted to do a preliminary pilot phase 1 safety study in language. And this particular device had been used, the North Star stroke recovery system. This had been used in human beings for motor recovery with epidural grid placed over the primary motor cortex. And we were offered the opportunity to experiment with that over some part of the so-called quote unquote language cortex. And we elected to use this dorsal pathway, action observation pathway, as our basis of our study. And so we did a functional magnetic resonance imaging task on some patients. We localized where action observation and imitation converged in the ventral premotor part of the brain. And then we used this epidural stimulator. I'll show you the stimulator here. That's the first operation. That's the opening for the first operation. And there's the stimulator placed in this first patient. And we performed speech therapy for 6 weeks, every day for 6 weeks. And we did that in 4 people who had this implant and 4 people who did not have this implant. And in fact, the people who had the implant did a little better. They were stimulated during the therapy. The raters were completely blinded. So the 4 people who did not have the stimulator wore caps over their heads. The tester could not tell whether or not they had surgical scars. The folks with the implants also had those caps. And so this was a carefully blinded study. Of course, from 4 patients with the implant and 4 without, we can't bring any new therapies to the community, obviously. But this is very provocative because the stimulation group did better. We think in our analysis that the stimulation group did better because 1 patient did better. And so we're trying to understand on an individual basis what makes people respond to therapy as opposed to others who do not. Obviously, the most available way to stimulate the action observation circuit is via behavioral therapy. And so we developed a study of observation and observation imitation in order to target this action of this dorsal stream, posterior dorsal language stream. And this type of therapy has now come to be called action observation therapy. And we did that with speech and language. Again, 6 weeks of computer-assisted therapy. And we did a number of MRI scans before, during, and after those 6 weeks of therapy. The 19 patients whom we studied are illustrated by their MRI scans, overlapping MRI scans on the left. And you can see that the left frontal lobe was primarily involved. And this is because we did emphasize patients with speech motor problems, as well as more anterior style Broca's aphasias. The therapy had some degree of success. It was more successful than the patients improved compared to baseline, more successful than not doing therapy. But the problem is, of course, that's true for many, many therapies. The vast majority of therapies that we use in speech for aphasia have some degree of benefit. The question is, do they have specific benefit in specific patients? And does any particular therapy have any special role as opposed to any other specific therapy in particular patients? And we don't know that. We know this therapy had a limited degree of success, no better or worse probably than a lot of other therapies. But with all of our imaging, we aim to discover more about what was happening in the therapy, for whom it would be beneficial, and how to turn this kind of work into a precision approach. So with that, we get into part 3, which is the individual differences. And the individual differences are fundamental, and personalized approaches to therapy will be critical. At first, we thought that when we did therapy, what we would expect is that the brain networks would become more like a normal brain network as a result of the therapy. And this did not turn out to be the case. Most physiatrists actually understood that because of the whole role of compensation. But there were at least 2 different patterns. Patients with moderate term recovery had changes more in the left hemisphere and became more like the normal model. Patients with longer term injury had more change in the right hemisphere and became less like the normal model. So this actually goes to the issue of whether it's left hemisphere or right hemisphere that's most involved in recovery. And the answer is, it depends. Predicting the therapeutic potential of our therapy, we wondered if individual variability would play a role. Patients are have variability within their own performance on a day-to-day, hour-to-hour basis. The Boston naming test score can be the same on 3 consecutive days with different errors. The scores can be different on different days. And this variability, we wondered, does it relate to the ability to respond to therapy? And the answer was yes. In fact, the more individual variability the patient has, the more likely they are to respond to our therapy. It's also true that the complexity of the task-dependent fMRI, but not the resting state fMRI, the task-dependent fMRI, and those are observation and imitation tasks, the complexity of that predicted improvement as well. And that's interesting and something we need to continue to follow up on. Next, the resting state. So we know that there are a number of different networks that are active at rest. And my student, Susan Duncan, demonstrated that those same networks are present in people with aphasia. There's obviously some missing activity where the injury was, but essentially the networks are present. And so the question is, do these resting state networks have any predictive value? And the answer is yes. The modularity of these resting state networks, in fact, correlates with stroke recovery. And the more modular, the more prone they are to therapy. Further, in terms of space and time analysis, we did a study using dynamic functional connectivity. And during the dynamic functional connectivity, the brain was in about 10 different states. This is always depends on how you do this, but we found 10 states of importance to us. And the most interesting thing is that one of those states, it was state number 10, we named it, actually did have a role in recovery. That is to say, patients who spent the most time in this state 10 had the best chance of responding to the therapy. And state 10, interestingly, is a state that is maximally different from all the existing the known resting state networks that have been described. So this separability of the networks, when you're in a state that's different from those, you have more chance of responding to therapy. And lastly, we did a artificial intelligence and machine learning experiment trying to identify, based on the functional MRIs of these patients, whether or not they were, who they were. So we tried to identify them just based on their response. And in fact, we could do that. And it was particularly easier to do that with the right hemisphere. Again, individual variability is key to stroke recovery, and individual variability will be a real important component when we start looking at precision medicine. So in summary, evolution is critical to understanding the neurobiology of language. Language representations are distributed, involving numerous pathways in many time-dependent states. These properties impact language recovery after stroke and do so on an individual basis. And finally, personalized or precision approaches to therapy will be critical. So before I end, I need to do some blatant advertising. If you want to learn about neurobiology of language, this is a great book about almost 100 articles on neurobiology of language from some of the best scholars in the world. And if you want to read about neurobiology of language or publish in an open access journal with gender balance, editorial board, double-blind reviewing at reasonable article processing charges, please publish in our journal, Neurobiology of Language, published by MIT Press in cooperation with the Society for Neurobiology of Language. Thank you very much for listening. Thanks particularly to my trainees and colleagues, and thank you all for your attention. I hope to see you in person at the next meeting. Bye-bye.
Hi, I'm Nick Ward from Queen Square in London. I've been asked to talk about advancing upper limb recovery after stroke, so it's a bit of a change in direction from the previous talks. I'm going to focus on how we might think about promoting recovery of the upper limb after stroke, and also what we mean by the term recovery. And towards the end, I'm going to try and highlight where I think the importance of brain imaging techniques might be in the framework that I'm going to talk about. I've got no disclosures to make. So let's just motivate why it's important that we do better. The Stroke Association in the UK have collected data that demonstrate that 45% of all stroke survivors feel abandoned when they leave hospital. And if you follow them up for long enough, you can see that patients actually tend to deteriorate over time. So at 5 years, patients are back to where they were 2 months after stroke. So the first key point is that stroke is not a single incident disease from which patients may or may not recover. It's a chronic and progressive disease, and it should be treated as such. So the question is, how do we do better? Is this a biological inevitability, or is there something that we can do about it in order to transform outcomes for patients. So the first thing that we need is a framework which will provide the basis for rational investigation. So here is our post-stroke brain, and the thing that we're interested in is an output from this system, and the output is essentially a behavioural outcome. And it's important to recognise early on that there are a number of different types of behavioural outcome. And if we think just very simply, for example, in the motor domain, you could consider both strength and control of movement, in other words, dexterity, for example, to be two separate parameters in that behavioural space. So how do we drive an improved output? Well, we need an input. And again, the input is behavioural. And once again, we can consider that there are a number of different components to behavioural training or behavioural inputs. And what we really need to begin to do is to start to understand how these components map onto one another. So how different components of the input map onto different components of the output. Now, that seems complicated, but it gets more complicated because the input-output relationships are of course going to be modulated by a number of states. And again, we can think of these in terms of brain states, both fixed brain states, which would represent the anatomy of the structural damage, or indeed fluid brain states, which could represent network dynamics that are going on in the post-stroke brain. And if we have a good understanding of how the input-output relationship is modulated by these states, of course, this will give us the ability to predict things, so predict outcomes, or indeed predict response to different types of treatment. But it also affords the possibility of modulating these brain states. So we think about drugs and non-invasive brain stimulation, and even things like enriched environments, as things that can change the brain state in order to change the input-output relationship in a positive way. And of course, one of the most potent modulators of brain state is in fact time post-stroke. Okay, so the second key point is that we can think of recovery as an input-output relationship which is modulated by brain states. And I think that's put in a very similar way by John Krakauer and Tom Carmichael in their book, where they describe restitution as being a function of behavior, so a behavioral input multiplied by representation, so in other words, how much of the brain is left times plasticity, which I've referred to as a brain state. So you can see that this framework gives us both a horizontal and a vertical axis, and I suspect that most of the discussion so far has focused on the use of neuroimaging techniques to assess brain states and how these may be modulated by various forms of intervention, and how it allows us to make predictions about outcome after stroke. But of course, if we really want to drive improvement in behavior, in other words recovery, we're really going to have to focus on this horizontal axis. So first of all, I'm going to talk about what the inputs might be. A couple of years ago, the Stroke Recovery and Rehabilitation Roundtable Consensus Group got together to ask whether we knew who we should be treating, how much treatment we should be giving, what the treatment should be, and when it should be delivered in relation to designing a randomized controlled trial for upper limb recovery. When discussing these points, it was very clear that they're all interrelated. So, for example, if we were thinking about how much treatment we should be giving, it's entirely dependent on who we were treating, what treatment was being given, and when it was delivered. But nevertheless, we tried to come up with some guidelines about what we thought about each of these parameters. I'm going to focus on the how much and the what. So the current recommendations in the UK at least are that patients should receive 45 minutes a day of each of these disciplines: physio, occupational therapy, speech language therapy and neuropsychology, each day for as long as they are willing to participate and they're continuing to improve. But of course the reality is that they get much less, and audits of stroke services in the UK show that patients are getting on average 16 minutes a day of physio and OT, 13 minutes of speech and language therapy, and probably no neuropsychology at all. So there are a number of clinical trials in upper limb training that have looked at what they've called enhanced dose therapy, and I've grouped them on this slide. On the left, those that I'd call pragmatic, in the sense that they were aiming to give an extra 18 to 36 hours over about 8 to 12 weeks. And this is a dose that could probably be incorporated into clinical services as they currently exist. Unfortunately, these trials were disappointing in their outcomes. On the right, there's a couple of studies that I think we can call aspirational, in that they delivered 300 hours of various forms of upper limb treatment to chronic stroke patients and ended up improving those patients by on average 9 to 11 points on the upper limb Fugl-Meyer scale, which is a significant and large change. This is a review from Kathy Lang and Keith Loza, which looked at the relationship between the effect size and the estimated time scheduled for therapy in a number of motor-related studies, and concluded that substantially more movement practice may be necessary to achieve better outcomes. In terms of how much more, well, that was addressed by this group from Australia, who asked the question, what is the amount of extra rehabilitation that needs to be provided to achieve a beneficial effect? And they found, by looking at a number of clinical trials, that you would need to provide an extra 240% of the intervention that you had decided to investigate. In other words, more than tripling what you were doing in that study. So if you designed a trial where you thought you should give 30 minutes of treatment, you should probably increase that up to about 100 before you're likely to see some kind of beneficial effect. So the third key point is that I think that we don't give enough rehabilitation to know what is possible in real life, and certainly not in clinical trials. Okay, we'll move on to the what segment now, which I think is a little bit more difficult than the how much. And the first thing I want to show you is this, which is from a Cochrane review, and it lists a number of interventions which are considered to be upper limb treatments. The ones that I've put orange dots by are the ones that I consider to be behavioural interventions. The others I think are modulators of brain state, so I'm going to ignore those for now. And I think the first thing you can see is that the level of evidence is for each of them is actually not very strong. But I think if you were a young occupational therapist or physiotherapist and you came to this as a menu, it'd be very difficult to know which of these to select for your particular patient. I think most of them, though, can be broken down into a couple of categories. I think the first one that we can think of is repetitive task training, and I've included robotics in this general area. And if we look at the evidence for repetitive task training, there is a low quality evidence that repetitive task training improves arm and hand function for up to 6 months, but not after. And if we look at robotics, this is a meta-analysis from Grefkes group, there was a significant but small improvement in motor control, but we're talking about 2 points on the upper limb Fugl-Meyer score, which isn't very much. The other category, of course, is constraint-induced movement therapy, and there are many studies that have shown the benefit of this over the years. I think what's interesting, and as pointed out by this review by Grefkes, is that the constraint approach only works if it has these three components. So firstly, there needs to be shaping. So shaping really refers to selection of the appropriate movement to be trained. And then you require mass practice through repetitive exercises, and finally the instructions for behavioural change. In other words, the transfer package that allows people to take any gains that they've made into their day-to-day lives. And if we go on and look at a couple of studies that we've already discussed, so the eye care study and the study from Janice Daly's group, you can start to look at what the active ingredients of those interventions are. So impairment focused, task specific, intense, engaging, collaborative, self-directed, patient-centered, over in the McCabe study. They certainly targeted impairment and then tried to move patients through to functionally meaningful tasks. So again, these interventions are becoming more complex. The difference between them, of course, was the dose. So when we set up the intensive upper limb neuro rehabilitation program at Queen Square, we understood that the program could not just consist of repetitive task training or exercises, that it needed to incorporate some of this complexity. So the overall philosophy of the program is to understand the individual impairments, to begin to treat people at the level of impairment, but also to move people towards being able to incorporate gains that they make into meaningful activities of daily living. We published our results in JNNP, and you can see that we have a good effect on the Fuggemeier and the ARAT and a number of other outcome scores. And it's important to notice that as well as the large change that they get between admission and discharge, they continue to improve at 6 weeks and 6 months after they've left the program. So in chronic stroke patients, these are quite impressive results, and they're certainly in keeping with the results from the McCabe papers. So we've had to think about what the active ingredients of this intervention might be. Remember early on I said that if we're thinking about understanding the behavioural interventions or behavioural inputs in our framework, we have to recognise that there will be a number of key components and that we will probably need to define what those are. So looking at the work in our programme, there's a number of things that we would want to highlight, the first of which is specialist knowledge. So it's absolutely key that we understand what set of impairments each patient has. So for example, why can this man not use his arm properly? You can see there that he's got profound scapular weakness. He's got an inability to bring his hand up to his mouth because of weakness at the biceps. He may also have other impairments, including increased tone or loss of sensation. And each of those will need addressing independently. Secondly, it's really important that you identify individualized goals. If you can get people working on goals that are important for them in their daily life, then you're much more likely to get buy-in when they go home in terms of increasing the dose of practice. When you've identified the tasks that need training, then we can go for high dose, high intensity practice. And lastly, we need to provide our patients with the tools, the motivation, the hope and the resources in order to carry on their own recovery at home. And this is a video that one of our patients sent us. So to us, this is very much like coaching. So this is what I mean by complex intervention. And when we're studying recovery after stroke, we need to take into consideration the complexity of the intervention that we are investigating. We've recently published a paper in BMJ Open looking at the qualitative aspects of the Queen Square Upper Limb Rehab Programme, and many of these ideas are discussed in there. And we also do a comparison of a number of the studies that I've talked about in terms of what it looks like the active ingredients are as described in those clinical trials. And I think that might be worth having a further look. So key point number 4 is that rehabilitation is really a complex intervention. In other words, it has multiple components, each of which interacts with the others. And as such, we should probably be using the MRC framework to study it. Okay, so the inputs have multiple behavioural components, but now we need to talk about the outputs, and it's equally the case that there are different aspects to recovery. Most simply, we can think about this in terms of the ICF, so we can think about the broad term disability in terms of disorders of body functions and structures, in other words impairments, disorders of activity, or disorders of participation. And of course it's true that patients can improve in each of those independent of the others. In neuroscience, of course, we are much more focused on disorders of body function and structure, in other words, impairments. So what do we know about changes at the level of impairment? Again, this is focused on the upper limb. So this is a paper from Thomas Twitchell, published in Brain in 1953, in which he described painstakingly the recovery process of 121 hemiplegic patients. And it was this kind of detailed work that led to stages of recovery being described by a number of people, including Brunstrom. So in this particular example, you can see that patients move from a flaccid paralysis towards normality. And in that process, there tends to be an increase and then a decrease in spasticity. And initially you see an absence of voluntary movement and then a return of synergistic movement, so in particular the flexor synergies, and then towards the ability to control single joints. So the point about this is it represents a number of discrete stages of recovery. How do we quantify that change in motor control in humans? Well, one way, and something that's certainly advocated by the SRRR, is to use kinematics for the upper limb. So this is an example from Grefkes' group in which three-dimensional kinematics have been used to look at recovery of motor behavior. So the point about this is it's a behavior that cannot be compensated for. So any improvement represents a true movement towards normal motor behavior. And what you can see here is that that improvement, that true recovery, only seems to happen for about the first 8 weeks. And after that, the curve tends to flatten off. And we see the same result with this paper from John Krakauer's group, which used two-dimensional kinematics. Again, the movement cannot be compensated for, so any improvements represent a true return towards normal behavior. But again, this return towards normal behavior seems to occur only in the first few weeks or so. So what we're seeing is some interesting things going on early after stroke. So we know about the rapid biological changes that occur in response to the damage itself, certainly changing the potential for experience-dependent plasticity. But what we're also seeing here is a rapid behavioral change that could probably be characterized as restitution or behavioral repair. And it leads to the hypothesis that behavioral repair requires neural repair. So in other words, moving between, for example, these Brunstrom stages would require some form of neural repair. So if we ask the question, can we promote recovery indefinitely? It depends what we're measuring. If we're thinking about impairment, then probably only for the first few months or so, according to the data that I've shown you. We can probably improve activity indefinitely, and we can certainly improve levels of participation indefinitely. So key point number 5, how long can recovery progress? Well, it depends what we're measuring. So I think you can begin to see, if we come back to this list of upper limb interventions described by Cochrane, that these approaches that have a very single-minded approach, these individual elements, don't really constitute a neurorehabilitation program. We really need to start thinking about what the active ingredients of our interventions are, and probably think about defining those treatments rather than through some spurious mechanism of action, which is probably not correct anyway. It would be much more useful to define those interventions in terms of the pattern of their effect on a range of behavioural outcomes. So, for example, if we were going to look at training motor control using an upper limb robotic device, or we were going to use a group-based online tele-rehabilitation program, as we did recently with the Enroll program, we might hypothesize that the robotic training would have an effect on motor control, and the online tele-rehabilitation program would have much more of an effect on self-efficacy. Just to highlight the point again, so these are results from the Queen Square Upper Limb Rehabilitation program. You've already seen the results from the Fuggemeier score but Amanda Strawson, who was a great physio, worked on the program, who did a master's course looking at the stroke impact scale in some of our patients. You can see that the Fugl-Meyer scores continue to increase, but actually if you look at the emotional scores from the stroke impact scale, you can see that they do initially go up, but then they come down again after discharge, and that probably has an effect on participation. So if we wanted to put together a really effective program, we'd take what we consider to be the key active ingredients from the 3-week program, and then we need to add some other elements that dealt with some of these problems that arise further down the line. So key point number 6 is that I think we need to define and differentiate these treatments, not by a mechanism of action of which we're usually unsure, but by their effects on a range of qualitatively different outcomes in what I think we should be calling outcome space. So today I've really focused on the horizontal aspects of this framework, the input-output relationship, and you might say to yourself, well, what's that got to do with brain imaging, and what's that got to do with non-invasive brain stimulation? And I think the argument that I would make is that in order to understand how to use brain imaging in order to make predictions about outcomes or response to a therapy, you really have to have a proper understanding of what you mean by a therapy, what are the components of that behavioral input, and you certainly need to have an understanding of what you mean by an outcome. When it comes to modulating brain states, and again, many of you will be interested in non-invasive brain stimulation, but there are also a number of studies looking at drugs now. The key thing to get home is the idea that drugs and non-invasive brain stimulation are not in themselves treatments. They will not drive behavioral gains in post-stroke patients. So what I've really tried to stress today is it's the behavioral input that drives the behavioral input, and modulating brain states may enhance the effect of the input to improve the output. And this is something that I think is really crucial. And one of the reasons for coming up with this framework is it's absolutely clear that this is not understood by many people who run randomized controlled trials. And the example that I would give you would be the recent studies of fluoxetine and the alpha-5 inverse agonist. But I think the same potential trap lies ahead for anybody thinking of doing large-scale randomized controlled trials using non-invasive brain stimulation. I don't propose to go into that anymore, but just to signpost you to the fact that I've been involved in a couple of commentaries about these recently published clinical trials, the fluoxetine studies and the alpha-5 inverse agonist study that was published in Lancet Neurology with Gert Quackel and with Tom Carmichael. So I'll refer you to those if you want to read more of our thoughts on those trials. Okay, so these are the key points from my talk today. Firstly, stroke is a chronic and progressive disease. Secondly, recovery can be thought of as an input-output relationship which is modulated by a number of states, including those in the brain. Thirdly, in terms of how much behavioural intervention we should be giving, well, I think we don't give enough of it to know what is possible currently. Fourthly, what should that intervention be? Well, again, it's important to realise that rehabilitation is a complex intervention, by which we mean it has multiple components, each of which interacts with the others. Fifthly, defining recovery depends on what you measure, whether we think about impairment, activity or participation, for example. And lastly, I think it's important when we're considering treatments that we should define and differentiate these treatments, not necessarily by what we consider to be their mechanism of action, which we will usually be wrong about, but by their effects on outcome space. Thanks for your attention, and I'm happy to answer questions.